Hello, good afternoon, and welcome to the first webinar on how to survive the system, practical skill for researchers, how to read and review a paper. During this challenging period of COVID-19, the European Society of Endocrinology recognizes the hard work and dedication that all the endocrinologists across the world, and in particular our members, are doing to continue with their research, support their patients, and develop their career pathways. That's why, as part of the ESE resources to support the endocrine community during this crisis, the ESE is providing a series of webinars to support the online education and the early career endocrinologists. Following consultation with our science committee and the early career community, ESE, the topics that are planned to do in this series are, this first one is how to read and review a paper, how to write a paper will be the second one, and grant proposal writing will be the third one. I am Mónica Marazuela. I am right now the current secretary of the European Society of Endocrinology. I work as a clinical endocrinologist, but I also do some research in Madrid, and I'm really delighted to chair this webinar. Today's talk, as I said before, will be dealing with how to read and how to review a paper. We're really lucky to have an outstanding specialist in the matter that I'm sure will bring very interesting ideas in the subject. I would like to introduce Professor Olaf Dekkers. He's an endocrinologist and epidemiologist at the Leiden University Medical Center. He's currently involved in guideline development for the European Society of Endocrinology, and is also deputy editor of the European Journal of Endocrinology. He's an expert in statistics, in methodology, and epidemiology. He has published more than 300 articles, including numerous clinical guidelines, and I really recommend you to follow his publications because many of his articles are really remarkable, and it would be a very interesting way to learn how to read a paper. We also are very lucky to have him today because he's an amazing speaker. So I'm sure we will all have a great time with his talk. Also, please remember to write your questions in the question and answer section, and I will try to ask them to the speaker at the end of the talk. So Professor Dekkers, you can start whenever you want.
Okay, thank you very much, Monica. After such an introduction, it's quite hard to meet the expectations. So you give me a difficult task, I have to say. But let me start with my conflicts of interest. I think I get no funding from industry. I never did actually. Probably good to know that I'm, as Monica already mentioned, I'm deputy editor of the European Journal. So I see a lot of papers and I get a lot of papers to review. And I'm member of the board of the Dutch Medical Agency. And if I can start with the end, my main message to all researchers is whenever you're reading a paper or reviewing a paper, please use your brains and keep doing that. The problem is that I have to talk 30 minutes more. I could have stopped here, but I'm not going to do it. And I would like to mainly give you a lot of examples on how I judge different papers. And I have a sort of outline. I think when reading a paper or when reviewing a paper, I myself ask 5 questions. So the first is more a general intro to the topic. And I think it's an interesting philosophical question. Why are we doing research? Why are we doing research with data? And then the other 5 questions are really important when reading a paper. So the first is, what is the question of the paper? The second is it valid? The the third question is it actually true? And a paper can be valid, but still be untrue. The further point is it relevant? So I'm a methodologist, but I'm also a clinician. And very often clinicians say, well, I can't judge the paper because I do not understand anything about methods. And I say, okay, it doesn't matter as long as you judge the clinical part of it. And that's about the relevance. And the final point is papers are published in isolation, but a formal judgment, and I think a final judgment, requires that you see a paper in a much broader context. And then I would argue it's not only about the question whether it's statistically significant or not. But let's first start with the first question, why research with data? And I would like to go back with you 100 years. And this is a famous scene among two very famous mathematicians. One was in the hospital, it was Ramanujan, and he was visited by Hardy. Hardy came by a taxi. Ramanujan asked him the question, did anything happen to you today? Do you have a nice story today? And if two mathematicians are talking to each other, they mean, do you have a nice mathematical story today? They were not talking about football. And Hardy said, well, I didn't experience much interesting today. But then he was asked about the number of the cab he was sitting in. And he said, well, that was a boring number. It's 1729. And Ramanujan thought about it 2 seconds. And then he said, well, that's a very interesting number because it's the lowest number that you can express in two ways as the sum of two cubics. I'm not a mathematician, but what you see here is that in mathematics, you can have absolute certainty, absolute scientific certainty without having real world data. And now think about clinical questions. Here, for example, do we think that eating sausages is related to cancer? Or do we think that this fancy red pill may be extremely expensive for example, Cushing's disease, works in lowering cortisol? Or do we think that radiation is bad for your health and giving you headache or even gives you cancer? I think there's no genius in the world that can, without going to real world data, whether an RCT or observational studies, can give you with certainty an answer to that question. So in medicine, there's no certainty without data. And then you can say, well, we have biology, and probably biology is enough to predict what will happen in humans. So think about cholesterol. We know from observational data that high cholesterol is related to cardiovascular disease. So if we have a drug that reduces your cholesterol, it makes sense that your cardiovascular risk will be reduced. And yes, this was the case. I think this is a very famous trial, the 4S trial that was published in The Lancet more than 20 years ago. And it showed indeed that reducing your cholesterol with a statin reduces your cardiovascular risk. You could say, wow, why spend, I think this trial costs 100 million euros. Why spend so much money? You could have predicted probably this already from biology. Well, that's not entirely the case. So take this example. We know that after myocardial infarction, people get more arrhythmias. So it would make sense from a biological point of view to give to those people drugs that are antiarrhythmic. And here you have a trial after myocardial infarction. It's a famous called CAST trial published in New England. And actually the people who were randomized to encainate or flecainate, which were drugs were supposed to reduce your risk of an arrhythmia, they got an increased risk of arrhythmias. So apparently biology cannot fully be predicted from what you find in the lab. And here's an example from diabetology. We all know that HbA1c is related to cardiovascular disease. So if you have a higher HbA1c, you have a higher risk of cardiovascular disease. And then you say, well, it makes really sense that if you lower with drugs the glucose levels, that it will lower your cardiovascular risk. But take the example of rosiglitazone. We all know that although it was really shown that it reduced your glucose levels, it actually did not reduce your cardiovascular risk. Might even be that it increased your cardiovascular risk slightly. I think the jury is still out whether it really increases the risk, but it did not decrease the risk. So I think the first learning point is we need real world data, we need observational studies, we need randomized trials, because reasoning alone, pathophysiological reasoning or biological reasoning, that does not perfectly predict what the effect of treatments in human in the end will be. The interesting point, however, is that there's no guarantee that even if you do a randomized trial, that the trial is positive, meaning that the drug that you hope will be successful in the end is truly successful. And these findings that you see here in the slide, this is a picture from a paper in Nature from 2013, but the results are quite consistent over the years. Here you can see that from all trials, randomized trials that are performed, only 50% of the trials shows a positive effect. And you have to think that before you're doing a phase 3 randomized trial, you have already done a lot of preclinical work, phase 1 trial, phase 2 trial, and still it's difficult to predict what in humans will happen. So to make it even worse, if you go to oncology, based on phase 2 trials, here we have more than 350 phase 2 trials, you see that only 5% were tested in phase 3, and of them, only half were positive. So this really means that it's quite uncertain whether a drug in the end will have a positive effect in humans. And that's the reason why we need data, why we need randomized controlled trials. So let me go to the first question when reviewing a paper. And the first question actually is, what is the question? And I get a lot of papers to review for the European Journal, but also for other journals. And I always try to force myself and ask the question, what is the question that the researchers want to answer? Because it's easy to directly go to the results, and there you get a lot of data. But here, I always say, many studies try to give answers in tables, in data, in analysis, but very often I have to guess what actually is the question. So 2 weeks ago, I had to review a paper including, I think it were about 90 patients. The research question was quite fuzzy, and they performed more than 400 statistical tests. And then I could say, well, there are a lot of data, a lot of tables, probably a lot of answers, because many of those 400 analyses were statistically significant. But if the question is unclear, it's unclear what the meaning of the data is. In general, very often I see that it's unclear whether the authors or the researchers really want to go into etiology, causality. Do we really want to know whether a certain risk factor is actually causing a disease, or is it about prediction? And with prediction, I mean that if you have a certain factor, that you can predict what will happen. And a predictor does not need to be causally related to the outcome. And even sometimes you don't even have a question, a research question at all, or even a vague question. And in brackets, the research questions should determine the statistical analysis, and otherwise things can go wrong. I will not go into details there, but give you an example. So on first sight, here the research question might be obvious. So it's about gastric emptying rate in patients with fibromyalgia, and the research question might be, and actually it was in this question, do patients with fibromyalgia have disturbed gastric emptying rate? You can discuss whether that's an interesting question or not, or you can say, well, I'm not interested in gastric emptying rate at all, but that's another question. As a methodologist, I have to say that this is not a case control study. I will leave it for now, but as an editor of the European Journal, if things go wrong already in the title, I'm a little bit pessimistic regarding the rest of the paper. It's like going to dinner with someone, first date, and then you say, what was your name again? So I think that's a problem in this study, but let's have a look at the second table and keeping in mind what was the research question. So the research question here is whether patients with fibromyalgia do have a disturbed gastric emptying rate. And then in table 2, I really start to puzzle, what is this about? Does it really make sense in a paper about fibromyalgia to compare premenopausal to menopausal women? I think it isn't. It wasn't specified in the math, that's why they were interested in that. And things can get even worse because this is a comparison where there's no power, so they can't say anything. It's comparing 7 women to 8 women, and then even look at the mean age, it's comparing 52 years to 41 years of age. And they even conclude that because it's not significant, there is no difference in age between premenopausal and postmenopausal women, which by no means make sense. So here I think really the problem is that for this table 2, there was no research question, and then the whole table 2 does not make any sense. Let's go to another paper. If you read the title reads, "A positive fluid balance is associated with a worse outcome in patients with acute renal failure." And now the question could be, do we think that this is about causality or is this about prediction? And please make up your mind 2-3 seconds what you think it is. And only reading the title, I think it's unclear because associated can be both. And you can say, well, I'm actually interested in the question whether if I give too much fluid to patients, whether that is detrimental for the outcome or not. Or I could say, I use this as a predictor because if I have someone with a positive fluid balance, that actually might predict a worse outcome, which is interesting in the intensive care unit. But it can be both, and for the analysis, it really matters whether this is about prediction or whether this is about etiology. So both are possible, I think. So the association between a positive fluid balance and mortality, is it about etiology or causality, or is it prognostic research? So let's go a little bit further, then you have to read in detail the paper. And then they say the aim of the present study was to analyze whether fluid management influences mortality. So here the authors say we're interested in etiology. This is about the causal relation between fluid management and mortality in the intensive care unit. And this is table 1. And then I'm starting to get a little bit surprised because normally in table 1 you see a kind of comparison. You see a comparison between people with, well, take the 4S trial, people who get statins and people who get placebo. And here you would like to see something like, who are the patients who have a positive fluid balance and who are the patients who have not? So this is a weird table 1 if you take into account what I think is the research question. So table 1 does not fit the research question here. And then if you go to the analysis, you indeed see that the authors were interested in the question of the effect of the positive fluid balance, and they say, and this is the main result, that if you have a positive fluid balance, then your mortality risk is increased independent of age and of SUBs and of heart failure and medical admission. So you have sometimes the research question is quite fuzzy, and in this case you have to read quite careful to see what the authors in the end mention, and only when reading through the analysis you say, well, I think that the research question is about the effect of fluid balance, positive fluid balance on mortality. So that was the first point. Always force yourself to ask the question, what is the question that the researchers want to address in this paper? Otherwise you can be blurred in data. The second point is it valid? And I would like to go to this study. That's a study published in The Lancet already more than 10 years ago. And it's a placebo-controlled trial comparing probiotics. And probiotics are a kind of bacteria, and we think they really do not any harm. And they compared it to placebo to see whether in patients with probiotics, the outcome after severe acute pancreatitis might be better compared to placebo. To their surprise, and I think to the large surprise, people with probiotic did really worse. So here you see a graph with mortality risk, and in red line you see the mortality risk in patients with probiotics. It's about 14% in 3 months mortality, compared to placebo was 5%. And then a scientific discussion started. Is this really a negative effect of probiotics? Is it a chance finding? Or was the study in any other way biased? And you can, for every paper that you see, you have to tell yourself all data are in need for an interpretation. And I think this is a kind of framework on how to judge that. You can say, well, it can be causal. In this case, you can argue that probably probiotics are really bad for you in acute severe pancreatitis. Or you say, no, I don't believe it's causal. And then if it's invalid, the study, you have to say, oh, I think it's confounding, or I think, for example, it's biased. And I would like to give an example of a study where I really think there was bias. So here we have a study again on rosiglitazone. For teaching purposes, it's one of my favorite drugs. And it's rosiglitazone in the record trial for type 2 diabetes. And here they looked at cardiovascular outcomes. It was a multi-center randomized open label trial. And normally we think that if it's randomized, that is the highest level of evidence. But be aware here, it's an open label trial. And then you have to think, what does that mean? Well, it means that all the endpoints that are recorded are open label. So for example, if someone gets pain on the chest and you do an EKG and you measure troponin, and then you say, well, do we think this was a myocardial infarction or not? Then actually you know whether the patient took rosiglitazone or not. And I think with drugs, it's like with having children. If you have children and you go to the football court, or you see all the parents there on the sidelines of the football field, all parents think their child will be the new Lionel Messi, which actually is not true. And it's the same with drugs. Researchers always think that their drug will cure whatever disease. So you have to imagine that if you have to fill in whether there's a myocardial infarction, it may be that you're slightly biased. And actually this was shown for this trial because Bruce Psetti, a researcher from the US, went to the FDA and said, can I have the case forms for the rosiglitazone study? And he asked himself the question, are there any problems with this case form? Well, that was the case. And what is a problem? For example, that a patient had a CT scan with a brain full of blood, but that there was no tick in the case form saying this was a cardiovascular event, which I think is a kind of mistake. And mistakes always happens, but he showed, as you can see in this slide, that if there was a problem with a case form, it was about 16% in the rosiglitazone group, he showed that if there was a problem, in almost all cases, it favored rosiglitazone. So apparently the doctors who were filling in these case forms were really willing to fill it in a way that favored rosiglitazone. And that's the problem of open label studies. So even if it's randomized, a study can still be biased and invalid. And then you have some biases that are a little bit more technical, but I guess most of you here in the audience are clinicians, and just use your brain. If you see a study like this and saying, well, what is the impact of a second primary tumor on survival in head and neck cancer? I hope you all will say, well, my guess is that if you have one tumor, you get a second one. That's not good for your survival probability. I hope that that's your first reaction. And if there's an analysis here showing that if you get a second tumor, like in the upper line of this graph, this line suggests that having a second tumor is good for your health. Well, there's no logical way it can be. And this is a more technical bias. As I said, this is called immortal time bias. But you don't need the technicalities to have a gut feeling that this can't be true. So please, doctors, go to your gut when judging studies. This can't be true, and the technical part of it, this is immortal time bias. So the fourth point is the question, is it true? And there I have a poll. Let's see whether it works. So the question to you is, just go to your gut feeling and hear what is the expected effect of bisoprolol, beta blocker, on mortality in patients undergoing vascular surgery. I cannot vote, but I hope the others will vote. 5 possibilities. There is a large increased mortality risk if you take it, small increased risk, no effect, small reduction, or a large reduction in mortality risk. Okay, well, that's great. So most people say, well, if anything, if I would give it a guess, I would say there's a small reduction in mortality risk. Some people say 16% say, well, there's no effect. A few say there's a large mortality risk, and a few say, well, probably there's an increased mortality risk when giving beta blockers. I think it's important before going to studies to make up your own mind. And I don't know whether you sometimes get these emails. I sometimes do get them. And there's an email from someone in a poor country and saying, well, I'm living in a poor country. I have some problems with transferring my money, and I've chosen you to give 5 million euros because you're a good guy. I believe you, and you can do with this money whatever you want. The only thing you have to do is give me your bank account. Then the reaction is, this can't be true. At least that's my reaction. I guess it's the reaction from most of you. And it should be the same in science. So here we go. This is a paper published in the New England Journal of Medicine already 20 years ago about, indeed, the effect of bisoprolol on mortality in patients undergoing vascular surgery. And before reading this paper, I think it's quite unlikely that you either have a huge effect on mortality, whether negative or positive. The problem with clinicians is that most of the time they stop thinking the moment they see New England Journal of Medicine. Then they say, well, this should be true because it's in the New England Journal of Medicine. So what is the effect on mortality? Well, actually in this study, this study showed there was an 80% mortality reduction. Here in the study this is the slide from a meta-analysis that was performed a few years after the publication of this trial. And arguably, this can't be true. So 80% mortality risk just by a little bit of bisoprolol, I think that's too good to be true. And I would like to give you the message that even if the study is published in New England Journal of Medicine, please stay critical. And what is it? I think, as I said, there is a kind of framework to judge papers. Well, is it causal? Well, probably it does something, but I think this is due to chance. Because it was a randomized trial, it was double-blind, so it's likely to be valid, but it still can be chance. And I would like to explain why this is the case. This was a kind of small study, and it only included a little bit more than 100 patients, which for a randomized trial is quite small. And it's a kind of rule that if you have a small study, you can get an extreme result. Yeah, it's easy to see that if I would like to know what the age is of the audience and I only ask 1 or 2 people, then it's probably I get an extreme result because I only pick up 2 younger people or 2 elder people. And the other point is indeed a result is not always true because it's published in New England Journal of Medicine. And why is it the case that if you have a small study that it's very likely that you have an overestimation of an effect? Well, it has to do with what we call statistical significance. Because if you have a small study, you need a large effect to reach statistical significance. And it has to do with the upper figure here. If you have a small study, the confidence interval around the estimate is wide, and you need a large estimation for an effect to be statistically significant in a small study. And on the right side of the graph, you can see a kind of extrapolation and estimation on how much the overestimation of an effect can be in a small trial. So the overestimation can go up to 50%. And as a rule of thumb, I think it's good to have in the back of your mind that a small study often gives extreme results just due to chance. And why is it then published in the New England Journal of Medicine? Because people start to say, wow, this result is so impressive, we have to send it to the New England Journal of Medicine. And then you have a kind of circularity. People start to believe it because it's published in the New England Journal of Medicine, whereas it was only sent to the New England Journal of Medicine because the effect was so large. And I think that's a kind of sign of a chance finding small study with unbelievably large effect. Well, this is a little bit technical and a little bit methodological, but I think the other point is the question, is it relevant what people found? Well, not everything that is statistically significant is clinically relevant. And here we have, for example, the comparison of calcium levels between men and women. And as you can see from the p-value, this is extremely statistical significance. 5.4 to the power minus 41. This is hugely significant. But look at the difference. Well, you can really question whether there's any relevant meaning based on the difference in these calcium levels. You might argue that probably from a biological point of view, there are some interesting points to make here, but the relevance can be questioned. And here's another example where I hope you all question relevance. It's about sitagliptin that was used for cardiovascular outcomes in type 2 diabetes. And before going to the cardiovascular outcomes, let's first go to the HbA1c and just have a short look at the graph. It's compared to placebo. And here you have the glycated hemoglobin levels over time. Well, how much time is it? Well, actually it's 4 years. And you see the difference at the end of the study. That's hardly relevant, I would argue. Probably this is significant, but the difference between sitagliptin and placebo over 5 years, that's really not much. So you can ask yourself the question, yes, you say, I see it's statistically significant, but is it clinically relevant? So please, doctors, when you judge papers, don't be fooled by p-values and numbers, but just ask the very simple question, even in a randomized trial, how relevant it is. And when I was a resident, there was a doctor always, when discussing papers, asking the question. He said, well, the only thing I'm interested in is whether it's significant. And now I would like to say to him, please, that's not the question a clinician should ask. Clinicians should ask the question, is it relevant for my patient, yes or no? And the problem with significance, it's a combined measure of effect size and study size. So if you have a huge trial, so most of the time already you know in advance that the effect they're searching for is quite small. So any large study, a study with 2 times 10,000 patients, without having read the study, I know in advance that the effect they're searching for is quite small. So a large study with a small effect can still reach significance, which does not imply relevance. And the final point I would like to make is to ask the question, what is the broader picture? And as said, we often stop thinking when the paper is published in New England Journal of Medicine and when the p-value is below 0.05. And many clinicians stop reading the method section of a paper if they read things like this, for example. We use the extension of a multivariable Bayesian hierarchical random effect model for mixed multiple treatment comparison. And I'm completely fine that as a clinician you do not understand this, but keep in mind that you're a clinician and you still have the opportunity and the right to judge a paper from a clinical perspective. So what is the broader picture of the sitagliptin study? Well, the broader picture is that indeed it reduces to a very small extent your hemoglobin or your HbA1c level at the end of the study. But more important, why are we treating those patients? Why are we treating patients with diabetes type 2? Well, that's to control their glucose levels, but we do that to the extent that we can prevent cardiovascular events, major cardiovascular events, but also microcardiovascular events. And in this study, mind you, this was compared to placebo. And they did a non-inferiority trial to show that sitagliptin was not worse than placebo for cardiovascular event, major cardiovascular events, all based on the considerations that drugs should be safe. But I think this is not what in the end should force us to think that this is really a good drug for our patient, at least not based on this study, because it's not worse than placebo. And I think you can't convince a patient to take a drug for 5 years and then tell them, yes, please take it because it's not worse than placebo. Then I think it's probably better to take nothing and do something about lifestyle. This is a famous example of rosiglitazone. This is statistics about meta-analysis showing that probably rosiglitazone increased cardiovascular risk. And don't be fooled here by statistics and people arguing that, well, based on whether you take the statistical analysis 1 or 2 or 3, it's either significant or not. But then you as a clinician, you should argue, it doesn't matter which statistical approach I take. In any way, for rosiglitazone, it's not going into the right direction because all statistical analysis points to probably an increased cardiovascular risk. And whether it's borderline significant or not does at this point not matter. And here the final example I have before my closing remarks and before taking some questions. What is the broader picture here? Well, the broader picture was there's a debate, and I think the debate is still not settled yet, whether if you take insulin, insulin itself increases your risk for cancer. And there was a huge debate whether the newer insulins, at least newer at that time, insulin datamir or insulin glargine, increased your cardiovascular risk. And then there was a meta-analysis, and the meta-analysis was trying to combine all the randomized trials that were out there to see whether insulin D-dimer increased your cancer risk. The conclusion from this meta-analysis here, it reads, in these randomized controlled diabetes trials, patients treated with insulin D-dimer had a lower or similar occurrence of cancer compared to patients treated with NPH insulin or insulin glargine. Okay, and you can say, well, fine, that's good for the patients. Then at least I'm happy to give them this drug because now I know it's safe. This is supposed to be the highest level evidence. It's a meta-analysis of randomized controlled trials. But make up your mind here, because how long do you think it takes before insulin will show an increased cancer risk? That might take a few years. You don't expect probably an increased risk, but to show an increased risk with truly an increased incidence of cancer in patients taking whatever sort of insulin, you need trials that go on for a long time. And if you look at the exposure time in included trials, it's 50 weeks with a maximum of a little bit more than 1 year. So for me, the broader picture here, that this is not reassuring. I would argue, well, it may be that after 1 year you don't see an increased incidence, but the broader picture is that we don't expect any effect on the incidence of cancer within 1 year. So please don't give a reassuring message, but the message should be, we should look for trials with a longer duration, a longer follow-up. So these were a lot of points on how to read and how to review papers. My main point is use your brains, but what are the more specific remarks? Biology itself is not enough to see what will finally happen or to predict what will finally happen with drugs, for example, in humans. Ask the question, what is the research question in this paper? It's not only about data and statistics, because the research question should guide the statistical choices. Then the question about validity, and there are many threats to validity. I have not given you a textbook lecture about bias and confounding, but keep in the back of your mind that any study can be biased, even randomized trials. The fourth question is it true? And even valid studies may not be true, and I think it's helpful just before going to the paper, ask yourself, what is my gut feeling about the result of this study before having read it? And small studies can just give large effects simply due to chance. As a clinician, always ask the question, is it relevant? And don't be fooled by p-values. And what is the broader picture? And for all data, I think we have to say they're in need of an interpretation. And we can ask ourselves the question, what is the conclusion? Taking into account different scientific and clinical angles. And with that, I would like to give the floor back to the chair. And my main message is just use your brains. So thank you. Monica, up to you.
Thank you so much for this amazing talk. I think it was a great job. And right now we have a couple of questions that I'm going to ask you. The first one, if there's a concordance between p-values and hazard ratio.
Yeah, so I think the p-value has one big disadvantage. If you have a p-value, it does not tell you how large the effect is. So there is a relation to a hazard ratio. So with every hazard ratio, you get a p-value. So preferably not only give p-values, and I think it's good to give an effect estimation, whether hazard ratio or odds ratio, with a confidence interval. And if people would like to give also a p-value, that's fine with me, of course, but a p-value never tells you how large the effect is, because in a very large study, a study can give a significant p-value with a very small effect. And then it's helpful to see the hazard ratio or the odds ratio. And then you can judge the clinical meaning of the effect. Based on p-value, it's impossible to judge the clinical meaning of an effect.
Thank you for your answer. The next question is there a specific algorithm that you would recommend besides the big five?
And the question is not certain what the big five means. Is it an algorithm of sending papers to other journals than the big five, or was it about my 5 questions? Can you help me out, Monica?
They are not your 5. Yes, it's your 5.
Yeah, so what I normally do when I review a paper is that I start with the tables. I have a look at the tables and see whether, without going to the text, whether the tables in itself make sense and give me a clear picture of what the researchers are wanting to do. And after the tables, I'm going to the figures of the paper. And if from the tables and the figures, it's unclear to me what the researchers want to do, or if I see that the number of statistical analysis in the tables are more than the patients that are included, most of the time I reject the paper quite fast, I have to say. So please come up with nice looking tables, nice looking graphs. Yeah, that's for me where I, as a reviewer, go.
Thank you. The next question is, why is it so many dodgy papers, as you have highlighted, can get published in reputable journals?
Yeah, well, that's a good question. So it's not all papers that I showed are in a way rubbish. So take the sitagliptin paper. I think this paper is really a valid randomized controlled trial. The only problem here is that you can question the clinical relevance. And the other point is that it's easier for teaching purposes to come up with a paper where I think is something not completely correct compared to a paper where everything went smoothly. So take the example of having a second tumor, that it's good for your health. Well, no one will believe this. So it's easier to make a point from a paper where something went wrong, but that's didactical. The other thing is that we have a lot of work to do, and many people don't take the time to review a paper in all details. That's just how it works. I think you can agree on that, Monica.
Yeah.
I get, I think, between 5 and 10 questions for reviewing papers. It costs a lot of time to do it properly, and clinicians often do not have the time to look into all details. I think it's a weakness of our system that we publish so many papers. I would love to have a system where we just publish a little bit less.
Okay, the next question is, do you recommend that confidence intervals be used for all point estimates? It would help with smaller studies.
Yeah, the simple answer is yes. Confidence intervals always give you a kind of feeling on how precise an estimate is. And sometimes you get confidence intervals that run from 100 to 1.02, and then simply saying it's significant makes no sense because the confidence intervals is so wide. So yes, always, please always give me confidence intervals.
There's many questions. The next one will be, what is your opinion on categorization of predictors that are originally on continuous variable?
Yeah, depends a little bit on what the research question is. In principle, start with using your categorical variable as a continuous where possible, because you lose a lot of power if you categorize your variables. So if you have, for example, age, I think that's a well-known example, many researchers start to dichotomize or the variable age, whereas I think in most prediction models, just keep it in as a continuous variable, as said, mainly for reasons of power. You lose so much power. So keep it in continuously.
The next question is, do you think peer review is enough for the quality of papers accepted in most of the journals?
The simple answer is no. I think for those of you who have some experience with big journals like JAMA, I think there the process of peer review very often is enough. That's really a tough peer review you get. You get 4 reviewers, you get an editorial process, you get 4 rounds of peer review, and then in the end you say, okay, most questions are really on the table and most validity issues have been spotted. For most other journals, I think the peer review process that we have is probably not completely enough. It works, but I do not know a better system than the one we have now. But especially the validity is often not judged enough. Yeah.
The next question will be, can a study made of 100 patients offer significant and relevant results?
But the simple answer is yes. But try to restrict. I hope then that researchers say, well, 100 is not really a lot. Depends a little bit again on what the outcome is. If you want to know, for example, in 100 patients to know whether mortality risk in half of the patient is higher than in the other half, and only 10 patients die, then the study is really small. So the question is here, it's not about the number of patients, but it's about the number of endpoints. And if only 5% of patients die, then you don't have any power to say something about mortality. Whereas if you want to compare two continuous variables, you will have enough power generally. Yeah, so it depends on the research question, actually.
Thank you. The next question is, how much weight do you place into the title of a paper, and do you have any tips for writing one?
That's good. There are 2 schools here. So one school says, don't give away the message of the paper in the title. I think any title should be short. If a title runs over 2 lines, that's too long, and people start wondering, why aren't the authors capable of having a shorter title? The other thing, I think you should not put in the title experience from center X or Y, because we sometimes get the experience from a Brazilian or an Italian or a Dutch center, because in the end you want to say something more general than just your experience. So keep it concise, short, and do not say where the paper comes from.
Thank you. The next question is, my old supervisor kept saying that more than 70% of the publications were not reproducible.
Yeah.
How can we trust publications on another note?
Yeah.
There's no publication of negative results.
Yeah, I think this is really an issue. So 70% is not reproducible. There are also people like John Ioannidis saying that probably 90% of all research findings are false. I think the reassuring thing is that we have a kind of freedom of research. So if I do not believe a certain research paper, I have the freedom to come up with another paper showing different results. And then you can say, well, research is not about single papers. It's about discussion between papers. So this really is a problem if you think that a single paper will finally give the truth. I think that cannot be. Research is about context, and that was my point 6. Always take the broader context into consideration when you judge the validity and the value of a paper. And I think then in the end, probably the truth will come out.
Well, we're running out of time and there are still some questions to go. I think I'll keep to one at least. Rare disease often has small sample sizes. How do you avoid overstating or overestimating effects despite the sample size being small?
Yeah, I think there are two things. If you have a clear research question and say, well, this is the biggest sample size we could get. And if you give confidence intervals and say, well, the effect estimation is uncertain, then I'm quite happy with that. And the other is that you should restrict yourself in the number of analyses you're doing to avoid false positive results. But if you open state, well, this is the number of patients we could get, we know the sample size is small, we limited ourselves in the research question, we have one or two clear questions that we would like to address, then I'm happy with small studies. Yeah.
Well, I think we just got to the time. There's still a couple of questions, but we could answer them to the people online and give them the answers. And I think we'll have to come to an end. It has been a really very interesting talk. I hope that you have enjoyed it at least as I did it. And thank you so much for being here with us. Thank you very much, our speaker. He was really outstanding as usual. And I would like to invite you to the next seminar that will take place in a week. It will be about how to write a paper by Dimitris Gloulis from Greece. And I think it will be also very interesting. And I think this series is going to be a great success. So thank you so much. And you are invited to be with us next week.
Thank you, Monica.
Bye.
Bye.